Welcome everybody to the 7th Annual Patient Summit on Diagnosis from the Society to Improve Diagnosis in Medicine. Good afternoon, good evening, I think even good morning to some of you. We are delighted to have you here. Our theme this year is Disparities in Diagnosis in the Time of COVID-19, a Multicultural Perspective. We have a great lineup of speakers that are not just multicultural, but multiple experts with expertise in a lot of different areas. These are our objectives. We're going to try to look at the problem of COVID diagnosis, both top down and across. So going from the political, the policy, the institutional, down to patient level interactions, concerns around COVID-19, which are very similar to some of the things that we have seen in the past, and with different groups, including women, people of color, and people with chronic conditions. Some of these things, as I said, are very similar to diagnostic disparities that we covered in previous patient summits, and that are areas of research for some of us in the Patient Engagement Committee of SIDM. So, and then we want to relate them to larger themes, and then we want to talk about solutions and get your ideas on that as well. So our speakers are Lieutenant Governor Peggy Flanagan of Minnesota, who's going to look at things from a policy issue for us. Ron Wyatt, who's an expert in patient safety and healthcare equity. Victor Montori, known for his work in evidence-based medicine and person-centered care. Marjorie Robertson, who is a long COVID survivor with a diagnosis story, a misdiagnosis story to share with us. David Myers, who will be talking with Marjorie, emergency room physician and bioethicist. So here's some of the bigger things that I sort of want you to think about as our speakers are talking. We're looking at the intersection of various influences on diagnosis, so the social and policy factors, institutional factors, and interpersonal. And that little tiny orange triangle in the middle is the diagnostic encounter, with all of these things coming to bear on it. So we want to sort of think about how these things influence each other and how they influence that diagnostic encounter, and try to tease out some of the problems and some of the solutions. Some of the underlying themes that we're trying to think about are the high-level social and policy issues, as I was saying, so the structural racism, the institutional racism, and many other issues. Historical background, structural background, philosophical, psychological, a lot of the things that underlie it, the risk and that are brought to this, and that we've certainly all seen in COVID-19, of a fractured, depersonalized healthcare system. Care, compassion, and respect as essential components of not only equity but accuracy. And then the role of the patient and how the diagnostic journey can lead to patient activism, and what patient activists can do, particularly how we can take the lessons from this and apply them more broadly to other areas of diagnostic inequity. So briefly, here is our agenda. We're going to have our 5 speakers for 4 speaker sessions, each speaking for about half an hour. So that will be 2 hours. We'll have a break around, let's see, I'm trying to calculate the time here. I think it's around a little before 7:30 Eastern time, 6:30 Central. just a short break. And then the speakers panel will be whatever time we have left, which we are thinking is going to be 40 or 50 minutes, a good long time at the end for audience discussion to kick these ideas around and to ask questions of our expert panel. So a little bit of housekeeping. You're all muted. Please put your questions and comments in the chat. The speakers will answer your questions in the speaker panel discussion after all the presentations are finished, but you can put them in as soon as you think of them. You can put them in during the panel. You can even put them in during the break. We'll gather the questions and relay them to the speakers. Speaker volume may vary, and unfortunately there's not much we can do about that on this side of the internet, so use your computer controls to adjust the volume so that the speakers are all at a comfortable volume. And that ends my part of the presentation. I will now hand this over to Dan Berg. As I said, the summit is organized every year by the Patient Engagement Committee of SIDM. So I'm going to turn it over now, turn the virtual podium over to our Patient Engagement Committee member, Minnesota resident Dan Berg, who is going to introduce our first speaker, Minnesota Lieutenant Governor Peggy Flanagan. She's going to talk to us about some of her experiences with disparities in COVID-19, both as a family member and a policymaker. We're really excited to have such a thoughtful, accomplished leader joining us in our summit. And Dan's going to tell you a little bit more about her. Dan?
Thank you, Helen, and welcome to a very snowy Minnesota. It's very unusual. It's been 104 years since we've had this much snow on October 20th. But I'm very pleased to be able to introduce Peggy Flanagan. Peggy is a mom, an advocate, a member of the White Earth Band of Ojibwe, and Minnesota's 50th Lieutenant Governor. As a former state representative, school board member, nonprofit leader, and community advocate, she now brings her experience in building coalitions and advocating for children and families to the Lieutenant Governor's office, where she works in partnership with our Governor, Tim Walz, to build One Minnesota. In addition to her role as part of the leadership team addressing the COVID-19 crisis in Minnesota, she has experienced a personal loss as a result of the pandemic. I've known Peggy for some 20 years, but something that I hadn't known until recently is that during her undergraduate years at the University of Minnesota, she served as a simulated patient actor with the medical school. So now it's my pleasure to introduce and welcome Lieutenant Governor Peggy Flanagan.
Hi, I'm Minnesota Lieutenant Governor Peggy Flanagan. I was elected in 2018 along with Governor Tim Walz. I'm a lifelong Minnesotan, a mom, a former state representative, and an organizer. As a member of the White Earth Band of Ojibwe, I am the highest ranking Native woman to serve an executive office in the country. I've built my career on standing up for children and families, low-income folks, communities of color, Native communities, and Minnesotans who've been historically underrepresented. In politics and policy, you hear a lot about those people. Well, I am those people. As a kid, my mom and I relied on public programs like the Supplemental Nutrition Assistance Program, or SNAP, to make ends meet. Medical assistance saved my life as a kid with asthma. I share this with you because our stories and the stories we bring to our work matter. The experiences we have and the preconceived notions we carry in our minds inform the way we serve the people we intend to help. Never has that been more clear than during the COVID-19 pandemic. COVID-19 has exposed and exacerbated the disparities in systems that have long been failing marginalized communities. This is very personal for me. In March, my older brother, Ron passed away from complications due to COVID-19. He had just been diagnosed with stage 4 cancer and started treatment. A few days later, he was hospitalized with COVID and he passed away. As we watch this pandemic fall hardest on communities of color and Indigenous communities, people with underlying conditions, people who have not had access to health care they need, issues of racial disparities in healthcare and the importance of effective diagnosis and treatment are more important now than ever before. While COVID-19 has drawn our eye to these disparities, they have existed for a very long time. So let's take a look at the bigger picture through the lens of Minnesota. Minnesota, despite our Scandinavian reputation, is a state with vibrant, diverse communities. We share land with 11 tribal nations. We are home to the largest Hmong and Somali populations in the country. Across the state, we have Native, Black, Latino, Asian Pacific Islander Minnesotans who help make up the fabric of our state. We are known as one of the happiest and healthiest places in the nation, except for communities of color and Native communities. In fact, Minnesota has some of the worst health disparities when comparing white communities to communities of color. People of color are less likely to have access to healthcare resources that fit the needs that they have and the needs of their community. And they're more likely to have chronic underlying conditions such as heart disease, high blood pressure, asthma, often as a result of these conditions. The systemic racism that is built into the healthcare systems is mirrored in individual interactions. These interactions perpetuate disparities in the care individuals receive, with devastating impacts on people, on families, and communities. We know that Black women are less likely to be believed when they report symptoms of pain or discomfort, a tangible barrier to getting the care they need until sometimes it's too late. I witnessed it when a healthcare provider recommended that my dad undergo a leg amputation, which he did. Later, we found out there was no reason for him to lose his leg. I breathe a sigh of relief when I am at an appointment and a healthcare provider who walks into the room is a woman of color, because I feel more seen and heard and taken care of. So we must ask, why are some providers so dismissive, consciously or unconsciously, of certain people, of certain communities, and of certain conditions? It's the stories we've been told about ourselves and others, the preconceived notions about who is trustworthy and who is not, our experience with people who are different from ourselves. When the burdens of misdiagnosis, improper treatment, or lack of care fall so heavily on people of color, that's not a coincidence, that's a pattern. And the consequence of that pattern is enormous. When COVID-19 started spreading across the United States, it was often referred to as the Great Equalizer because it seemed to impact everyone equally. Nothing could be further from the truth. COVID-19 has exposed and exacerbated health disparities that have existed for generations along lines of race, income, and ability. In Minnesota, people of color and Indigenous people have increased exposure to COVID-19. When Native, Asian Pacific Islander, and Latino Minnesotans are diagnosed with COVID-19, they are more likely to be hospitalized or admitted to the ICU. Native and Black individuals have the highest age-adjusted rates of death from COVID-19 in the state. This story did not begin with the first case of COVID-19 back in March. It has been generations in the making. It is about wealth gaps. Native people and people of color are more likely to work low-wage, frontline jobs that put them at increased risk of exposure. It's about health disparities. These communities have higher rates of conditions like asthma, high blood pressure, heart disease, diabetes. These underlying conditions that put you at risk for more severe symptoms. And it's about access to healthcare, having the resources necessary to take time off work, health insurance to support getting the treatment you need, and a trusted healthcare provider with necessary resources to be able to provide care. Knowing that this history does not start or end with the COVID-19 pandemic, the question becomes, what can we as a state government do to move the needle? On health disparities, on misdiagnosis, on access to care, the first step is to acknowledge that racial disparities exist and eliminating them deserves focus and resources. When the pandemic began, Governor Walz and I established a number of working groups that brought together teams from Minnesota state government and focused on specific aspects of the pandemic that we knew needed attention. Examples include food security, education, childcare, and critical care supplies. One of these working groups was the Community Resiliency and Recovery Working Group, which helped us to embed equity and anti-racism into our pandemic response. Because of their work, we collect and publicly report data on COVID-19 infections, hospitalizations, and deaths disaggregated by race, so that we can pinpoint which communities are being hit the hardest, and then we can take action. We work with nonprofit and media partners to distribute translated, culturally specific public health materials so that folks know why and how they should protect themselves from COVID-19. This includes hosting important announcements that were live translated into American Sign Language, Hmong, Somali, and Spanish. We have offered free testing pop-ups across the state in partnership with these communities. These pop-ups are easy to access and in trusted locations. No ID, insurance, payment, or even symptoms are required. And I'd really like to emphasize the two words there, in partnership. When healthcare systems can be the place where people experience anxiety or mistrust, we must find a way to bridge those gaps and keep people safe. We have worked with trusted community partners like the Black churches on the north side of Minneapolis to tribal governments across the state to provide folks with the information, personal protective equipment, and testing they need and frankly deserve. And while this work has not eliminated health disparities in COVID or more broadly, we are committed to investing in these relationships that will help us change the story. We can't change hearts and minds through policy, but we can put guidelines, expectations, and resources in place to help get folks the healthcare that they need and deserve. This work starts with recognition of systems, past mistakes, and the preconceived notions we carry about those people who may be different from ourselves. All of us are capable of making a snap judgment that dismisses someone or prevents them from getting the kind of help or care that they need. We measure what we care about, so get the data, even and especially if it indicates failure. Care about that failure so that you can serve people in the way they need to be served. And then from awareness, we must take action. It's about building relationships and setting measurable, defined goals that will change those failures into successes. Consider who is at the sometimes metaphorical table when decisions are being made. Do the experiences around the table reflect the experiences of the people you serve? Who is already doing the work in community to keep people informed and healthy and safe? Find good ways to partner. Invest time and resources into anti-racism and equity. Embed those viewpoints into every decision you make. We are in an unprecedented moment where the stakes have never been clearer or higher. And all of us operate in systems larger than ourselves, built on foundations of racism, sexism, xenophobia. Well, we must actively choose to do something different. That's my call of action to you today. To think about what you can do differently to provide better care for all of your patients. Let's change that story together. Thank you.
Thank you so much, Peggy. That was really a wonderful presentation. I hope that sort of sets the stage at the policy level. We will now go to our second speaker, who is Dr. Ron Wyatt, who's an internationally known patient safety and health equity expert. Ron's a vice president at MCIC Vermont, a former patient safety officer for the Joint Commission for Cook County Health in Chicago and for the Department of Defense, among many other positions and honors. Ron is considered one of the deep thinkers in patient safety and healthcare equity, and we are honored to have him as a SIDM board member and honored to have him with us today to talk to us about some of the historical, structural, and psychological factors that underlie disparities in diagnosis. Please join me in welcoming Ron Wyatt.
Hello, everyone, and this is Ron Wyatt. And first, let me just thank SIDM and all of the participants. Thank you for your time with joining us for this very important conference that includes some very important topics that we all need to know more about and learn how we can apply this knowledge to what we do in our everyday lives. So truly, genuinely, thank you for being here with us today. First, I'd like to start just with a little bit about who I am. I'm an internist by training, practice mostly in St. Louis, and I'll come back to that, and here in Alabama for over 25 years. During that time, I have worked, I would say, passionately on issues around healthcare disparity and health equity. I chair the IHI Equity Advisory Group and also serve as faculty in the Pursuing Equity Initiative at the Institute of Healthcare Improvement, as well as serving as core faculty at the Accreditation Council for Graduate Medical Education on a very important collaborative that aims at addressing healthcare disparities. So I bring both subject matter knowledge and, I would say, experiential knowledge to this topic. I will start by saying I did grow up here in rural Alabama, and at the time, the healthcare system was still segregated. I recall as a child going to a segregated general practitioner's office where at the time Black people could not get appointments, and there was a separate waiting area in his practice for Black people. So I share that because I think it's real important that we begin with history and what I would say are historical injustices in healthcare that have been expressed really back from, for African Americans, I would say 1619, for indigenous populations, really 1492. So we have to understand the history and the history of injustices in healthcare delivery that we're struggling with all these years later. So as we go through that, then I want to begin with, I think, another story that begins to demonstrate the challenges around decision-making and diagnostic error and decision-making that occurs all too frequently. And then all too frequently ends again in preventable death or harm. So I share a story of a 38-year-old African-American female who came to an emergency department at a large medical teaching center. The patient came in with symptoms of right-sided weakness. The patient was then seen by triage, by nursing, by medical trainees, and by the emergency department attending physician staff. Part of her history was that she did have borderline hypertension. She also informed the emergency department that her dad had died a few weeks before. So in the decision-making process, it was determined that the patient most likely was suffering from grief and depression from the death of her father. Some lab work was done a CAT scan of her head was not done. And that was even mention of the possibility that the patient was suffering from some type of what's called a conversion reaction. That was, again, in response to the loss of her father. The person was sent out of the emergency department. She returned within 72 hours, and at that time she had completed a dense stroke that left her with permanent disability. And when we look at the diagnostic challenges around clinical decision making, many of them, over 50% of the misdiagnoses are made in an ambulatory setting. And when we look then at the types of diagnoses that are either missed or delayed or not made, they're typically cancer diagnosis, infectious disease diagnosis, or vascular diagnosis, as in this case. So then we begin to think about, well, what is it about this patient that led to such a tragedy? And that's where we have to begin to think about, understand deeply, and educate ourselves and our teams on the components that I believe existed in a case like this. And we can start just with one type of bias. And as we talk about diagnostic error, there is a list of different types of biases that we face and deal with. Here, I would say that what happened was a series of things. One is again, implicit bias, that unconscious reactive thinking that happens that is not intended to be in some way bad, or is not intended to hurt people, but in fact, the evidence suggests that it does. So understanding that we make these decisions that are based somewhere other than our intent to do a good job as healthcare providers. So this unconscious, implicit part of our brain operates in a way that leads to a decision that leads to the outcomes that we do not want and did not expect. So understanding just the role of implicit bias and the other things that play into implicit bias. We have to talk about stereotyping and what stereotyping is in a healthcare setting, where our brain again tells us something about a person that is not true. It's a general idea, picture, frame of a person. And this could be from the way a person speaks, where they're from, what their sexual orientation or gender identity might be, what a person's religion is, what language they may speak, and what the race is. And we'll talk about that next. So then we see a person and we make some decision about that person. And the research tells us that those decisions are made within 7 seconds of seeing a person. Within 7 seconds, our brain starts to make decisions and start to think through something about this person that can potentially lead to a misdiagnosis, a delayed diagnosis, or the wrong diagnosis. So then understanding the alignment then between implicit bias, how we stereotype, and then the next part that we have to think about is how does structural and institutional racism play into decision making? What are the policies and the procedures in our systems, in our organizations that can lead to poor outcomes for people? Is it somehow related to insurance status? Again, is it somehow related to something about the innate feelings a person have against another person that's based on nothing more than skin color? So understanding then, how does racism operate in the organization? That means that is there somewhere in your system that advantages one type of person, but at the same time, it disadvantages another kind of person based on nothing more than what we think of as this concept of race? And how does that play out then in the policies we make, in the social settings that we're in the training that we take, and the people that we hire, and the people that get promoted? And that gets into a discussion about diversity and inclusion that we won't go into. But understanding that, looking at our policies, asking ourselves who is the population that we serve, and is that population's voice included in the systems that we develop in our organizations. Experience tells me that one of the things that happens in organizations is that there is some level of mistrust, distrust, or lack of trust that primarily Black and brown people have when engaging with the healthcare system. And again, for that, we need to go back and look at the history that brought us to this point. And part of that history includes some of the cases that we know about, that we talk about, that we discuss. We can go back and talk about, for instance, the Tuskegee syphilis studies that we all know about. As I practice here in Alabama, the echoes of that study are still alive here. And there are still people that remember, and the stories have been passed down about the Tuskegee syphilis study that built in levels of mistrust for the healthcare decision-making system. This is particularly acute when we look at the numbers of Black men that do not trust the healthcare system. That's somehow tied back to the Tuskegee experiment. The next I think many of us know about is the Henrietta Lacks story, and how the cells from Henrietta Lacks were used for now over 17,000 patents, and the lives that Henrietta Lacks cells has saved, and the scientific advancement that now what we know as the HeLa cell has contributed to modern health. Here's a case where the patient and the patient's family never knew that her cells were being used in such a way. The next one is Marion Sims. Many of us have known of him in medical school and training as the father of modern gynecologic surgery. And in fact, what history tells us is that Marion Sims operated on Black women that were slaves, or some that were owned by him, without general anesthetic. And you might know that recently, in I think 2018, the statue of J. Marion Sims that was in New York City was taken down once this historical injustice was finally revealed. Also, there's a history of the oral contraceptive experiments that took place in Puerto Rico, and the level of no informed consent that was a part of those studies that were called La Operación there in Puerto Rico. And then if we look at a more recent story from a book that's called Organ Thieves, and how Black people organs were used for some of the early work in organ transplantation. So when you begin to put these stories and others together, you begin to understand the levels of mistrust and distrust that have to be restored if we're going to proceed in working in teams with people and communities to intervene on their behalf, and more of a collaborative partnership versus a unilateral system that I believe has existed for far too long. So then trying to regain that trust requires several steps. And we've gone through some of those. One is understanding the history of what has happened. The next step is understanding there are populations, Black, Indigenous, and other people of color populations here in the U.S. and dare I say globally, that have been devalued. So then understanding that there are populations that have been devalued, and then how we go back and restore that value to demonstrate that all human beings have value in every system of health and health care. And we need to restore that value. We need to make sure that the dehumanization that's taken place over centuries is once and forever eliminated. It may be that part of that process is that we think about restorative justice principles and how we go back and possibly apologize for some of these historical injustices. And then, especially in this era of COVID, look at in a system how resources are being allocated. Well, what does that have to do with diagnostic error? Well, if we know in a system where you're making clinical decisions that the resources that you need in your system might not be available to you because you are under-resourced in that community or in that zip code, then you might not make the right diagnosis. There may be a delay in the diagnosis, or in fact, there may be a misdiagnosis. So that's part of when we think about diagnostic error, what does the system look like? And some of those latent conditions, we would call them, in the system. Is there proper staffing? Is there proper PPE? Is there proper supplies? Is there proper equipment? Does the equipment work? Do you know where the equipment is even? And we know that if we look at across systems, the allocation of resources is also not equal. So that plays into the delays in diagnosis that we see, or we think we see, in healthcare settings. So then addressing historical issues, and part of that again is going back in your system, in your organization, and finding out more about the history of your organization and how it got to be where it is today. And then finally, then when we look at the trust issue, there's another area to take a look at, and that is having humility. And we talk about cultural competency, and many organizations have their cultural competency learning modules. And all too often, from my perspective, organizations have these learning modules, people go through them, they've almost become a check the box exercise. So we have to think about how to go beyond that. So we think about then cultural humility, and I'll talk about structural humility and structural competency. So I'll share another story from a wonderful, wonderful physician that I met when I finished training in St. Louis, Dr. Venable. And for those interested, you can look at the story of Dr. Venable there in St. Louis and the challenges he faced as a Black physician in practice there in St. Louis, everywhere from being on staff at an academic medical center to just simply trying to build a house in a neighborhood where people did not want him to live there. So Dr. Venable was there in St. Louis when I finished my training, and I was just fortunate, and I would say blessed, to have met Dr. Venable at a meeting. And this was within a few months after finishing my training and was preparing to go into practice. And Dr. Venable and I had the most memorable conversation that relates to what we're talking about. He said, right now, you, meaning me, have all this knowledge. And he said, I would say lovingly, you think you're really smart and that you know a lot of things about medicine. And he said, in fact, you probably do. But the patient knows more about it than you. So when you start to see patients, if you're going to be successful in practice, and dare I say, not just in practice, but in life. But what he said was, if you want to be successful, then and make the right diagnosis, the first thing you need to do is sit down and listen. Listen to what people are telling you. Listen to the story they tell you. He said most of the time, and he used a number over 80% of the time, people will tell you what is wrong with them. All you have to do is listen and take in and process what you're being told in a humble way. That was his word, in a humble way. Then repeat back to that person what they told you. Use all of your subject matter knowledge to try to make the right diagnosis and come up with a plan to take care of that person. And he said, if you do that, you're going to make the right diagnosis most of the time, and people are going to tell everybody in the community that that guy is really a smart doctor. Go see him. So that's the part about just having the humility to listen to people. I was also fortunate in St. Louis to be trained by one of the, I think, foremost diagnosticians ever in medicine, a guy named Joe V. Sapara, who was deceased a couple years ago. Dr. Sapara wrote a book called The Art and the Science of Bedside Diagnosis. And if you ever get a chance to look at this book, I was fortunate enough to be on his team at the St. Louis VA multiple times. And just looking at the art of it. And the art, he would say, is building trust and listening. So as trainees, then we would go to the bedside and we would look for all of this information about the patient. We would try to get the history. We would look at the data that was coming through the diagnostics, and then we would, as we called it, nailed, quote unquote, the diagnosis. The next day, all too often, more times than I want to admit to, Dr. Sapara would come in for the attending rounds. He would sit at the patient's bedside and he would say something like this: "Tell me what's wrong with you." And the person would start to give him information that we had not received from the person. And we would just sit there and just kind of shock and awe, and sometimes even, I admit, rolling our eyes that we've been here all night trying to understand what's wrong with the person that has been admitted, and here's Dr. Sapara, who can sit at the bedside and within minutes tell us what the diagnosis was. And it's the same principles that Dr. Venable shared. That is listening and being in a setting where the person trusts you enough to tell you what's wrong with them. So that's the humility part of it. In clinical settings now, I talk about structural competency. And structural competency in a clinical setting is when that person comes to see you. That person may not look like you, may not have the same sexual orientation, gender identity, may not speak the same language, may not dress the same way, may not love people the way you love people. But that person deserves to be respected and listened to. And then you wait as a decision maker, as a clinical decision maker, to recognize what's being shared with you and then to respond. And respond means look at all the tools and resources that you have available and how you can bring that system of care together in a team. So communicating with the person seeking care, communicating with the team, understanding what resources you have that you can bring to bear to make sure that you're making the right diagnosis in a timely manner, and then seeking the right interventions for that person so that you avoid any kind of preventable harm or I dare say preventable death. So then understanding structural competency means recognizing and responding. And you also do that with a high degree of humility. Chinua Achebe, I often quote, is a person who wrote a book called Things Fall Apart. And I paraphrase Chinua Achebe when he says, "You cannot enter my house through your gate. So in order for you to come into my house, I have to give you permission. And you come in through my gate. And then we can sit in a bidirectional way, listen and understand each other. Then in a partnership, we can make a diagnosis. We can make a treatment plan. We can implement that plan. And we can understand and trust each other." And so that's I think a key to this. Some of the other structural things would be in organizations to prevent delays in diagnosis or misdiagnosis or wrong diagnosis is to make sure that there is teamwork, that there is a trained in degree of communication that everybody understands, that the team is interdisciplinary, and that there's a degree of professionalism on that team, so that there is what we call a culture of safety on that team, so that people can speak up and share their thoughts and share their ideas, because it might save a life, or it might prevent the wrong diagnosis, or it might prevent some other kind of intervention that wasn't needed or should not be used. So teamwork is essential. Simulation training is critical. Going through process of how we make decisions, going through implicit bias training, I think is really critical to think about as a institutional intervention. Understanding how to use structural humility, which means lifelong learning, and it means self-reflection. It means being taught by the people that we serve. It means listening to the people that come in so that we can do the right thing, but we can also do what's right. So as we put all this together in a system of care, both the quantitative as well as the qualitative, There's some other things I think that needs to be brought to bear in systems that can lead to better outcomes for the people we serve. It can build trust in the people we serve. It can build higher levels of trust, cooperation, and collaboration in communities. That is that we respect people. And you build trust when people respect you, that we show empathy, that we understand what empathy is, that we partner with people, that we show compassion when we engage with people, that we do not remove a person's dignity in the care that we provide. And I'll pause there for a second and share the case of Mr. Duncan, who came to the U.S. a few years ago from Liberia. He came to Texas at the beginning of the Ebola outbreak there in Liberia. He went to a hospital there in Texas with a high fever. He told the ER, I'm sure many of you heard the story, he told the ER that he had been in Liberia, where by now we knew that there was an Ebola outbreak. At that emergency department, after he was seen, in fact, the medical record initially did not show that he had a fever. He was sent home with acetaminophen, a Tylenol. His symptoms progressed. He got worse. He came back. He had Ebola, and he died. And that, again, set off all these thoughts about what was operating at the emergency department. What was the environment that people were in, or that systems put people in, that we make decisions that can lead to an outcome like with Mr. Duncan and Ebola. So we have to look at the system as leaders, and now I'm speaking primarily to leaders. Do you know the environment that we're putting people in? Do they have the resources? Do they have the staffing? Do they have the training and education that's required, especially in the time of a pandemic? And then I'll close by saying that in order to get to the right diagnosis, the timely diagnosis, and not miss a diagnosis, then we have to care, and because we are caregivers. So I think that if there's anything like a secret sauce or fairy dust in this process, I'll go back to my dear Aunt Molly, who raised me in Alabama, and she would just say, you have to love people first. So we have to love people, and we have to love our teams, and we have to love our organizations, and we have to love our community. So that means bringing the community into our system. It's difficult and challenging to love a community when you don't know who the community is. So I will stop there and say thank you so much for this time that you have devoted to listening to me. And I hope that there's something in what I said that you can take and use or further investigate or apply in the situations that you may find yourself in. So it's an honor to have been able to spend this time with you. And I look forward to your questions and feedback. Thank you.
Thank you so much, Ron, for that sort of amazing trip through history and sociology and psychology and the forces that act on trainees and doctors and patients. If you all have questions for Ron, please don't forget to put them in the chat while you're thinking of them. It's easier now than when we're in the middle of the patient panel. I want to introduce our next speaker, who is Victor Montori. Victor is also a luminary in the world of evidence-based medicine and patient-centered care. He is professor of medicine at Mayo Clinic. He's an endocrinologist and health services researcher. He's a recognized expert in evidence-based medicine and shared decision-making, and co-developer of the concept of minimally disruptive medicine. He works in Rochester, Minnesota at Mayo's Knowledge and Evaluation Research Unit called the CARE Unit, to advance person-centered care for patients with diabetes and other chronic conditions. Victor's perhaps best known these days for his website entitled Patient Revolution and his book called Why We Revolt, arguing for a return of kindness and compassion to healthcare. Victor?
Thank you very much for the opportunity to have me today. I would like to speak on the patient revolution for careful and kind care for all, and the context of the COVID-19 pandemic and how this affects the possibility of adequate diagnosis. This slide has my email address as well as my Twitter handle, and I invite you to contact me through either of these means if there's an opportunity for us to have additional conversation that does not occur during the Q&A component of this panel. I would like to also ensure that I have no financial relationships to disclose. I derive my income as a salaried physician from the Mayo Clinic. I conduct research at the care unit, but we do not take, have never taken any funding from any for-profit corporations. And I have a non-for-profit organization, the patientrevolution.org, that I chair the board as a co-founder, and I do not derive any income from the organization. We published in 2017 the first edition, and just a few weeks ago, the second edition of Why We Revolt, a patient revolution for careful and kind care for all. And I do not derive any income from this book. All the proceeds go to the Patient Revolution organization. At the center of my concern is care. And while we have seen a proliferation of adjectives around care, such as sick care, health care, patient-centered care, evidence-based care, and high-value care, at the center of it all is this noun, care. We should not be distracted by the adjectives. This noun, care, perhaps it's a verb, to care, is essential to the reason why we're all here. It's essential to why we have a healthcare system. Care is, in general terms, is the ability to create conditions for human flourishing. In the case of healthcare, it requires the caregiver to notice that the person receiving the care has a problem. Noticing that problem and turning to that problem to then respond effectively to it, respond in compassionate ways, respond in competent ways. So noticing and responding constitutes care. The person approaching the patient needing care approaches exclusively with the intention to care, with no other potential for gain. And in the process of care, if there is continuity in that relationship, a relationship occurs. And this relationship is important, particularly over time, as people might have unintended consequences of the care they receive. And this relationship allows people to recover from disappointments and pursue their goals again. So care is, again, the ability to notice a problem and to respond effectively to it. Here is Maria Luisa, who is a person from Peru like I am. Her picture has joined in these presentations for a number of years. And when you look at Maria Luisa, you see a lot of healthcare on the right-hand side of your slide. But you look at Maria Luisa's face, you look at her expression, and you realize that there will be a number of words to describe her, perhaps tired, depressed, lonely, overwhelmed, but it's unlikely that you will use the term healthy. So all that healthcare and so little health. Why is that? Healthcare today has corrupted its mission and has stopped caring. When patients come in, they're nothing more than a blur. Sometimes because we see them too quickly. Sometimes because we see them too close as a biopsy result or as an x-ray or as a laboratory test. Sometimes because we see them too far away like a statistic. Sometimes because we see them only through their representation in our electronic medical record as a cloud of data. But the patient remains blurry to us. We meet with the patient in an agenda that is already bloated with must-dos and check boxes and procedures and documentation of care rather than the care itself. And the clinicians end up at the end of a day of seeing these blurry patients at a loss, unable to make connections, emotional, intellectual connections with their patients, and lost. To get through the day, clinicians have tools like guidelines or quality targets or choice or innovations, but these allow the clinician to respond to people like Maria Luisa, but that is not the job. The job is to notice and respond to Maria Luisa, not to people like her. So the result of industrial healthcare is that 40% of the time when patient and clinician are together in a room, 40% of the time the clinician is feeding the computer, is attending to the needs of the computer, not of the patient. It means that 40% of our patients with chronic conditions are reporting unsustainable levels of burden of treatment. All the medical errands transferred to them and their caregivers are not implementable. And patients are at the verge, 40% of them are on the verge of discontinuing some of the tasks that we've asked them to conduct. And 40% of our clinicians, our pharmacists, our therapists, our nurses, our physicians, 40% of them exhibit symptoms of depersonalization and inability to show empathy, symptoms of burnout. This is the impact of industrial healthcare. Now, industrial healthcare uses a particular language that shapes our thinking and shapes our action, and shapes our thinking and our action away from care. In fact, it starts with care as something that can be delivered by a provider, which is the same term that is used whether the provider is a person or an institution, an organization. The patient is someone who joins up with the provider to deliver this care, and for that task is expected to be activated. And the activated patient and the provider deliver care and show that care to the payer, who has to then decide and judge whether this care was of high enough quality and low enough cost, in other words, of high enough value for that care to be paid for. The accountability, therefore, is on the patient and the provider, and the payer is the one that judges whether the care was the right care for this patient, that the care was of high enough quality, of low enough cost, of high enough value. This is not the language of caring. This is the language of the business of care, is the language of industrial healthcare that processes patients rather than cares for them. There is an alternative to this. That alternative requires our organizations and requires professionals and requires patients to master a trick. And the trick they have to master is the trick of having unhurried conversations. Unhurried conversations are conversations in which that could be very brief or they could be very long, but in which we feel that we belong in that conversation. We're able to have the rhythm of care, the right tempo to connect our souls and make sure that we are together. The right tempo that allows us to identify the song of our care and dance to it. Not a hurried one in which the song is maybe recognizable, but you cannot dance to it. In this unhurried conversation, which doesn't have to be long or short, there has to be no waste, but there is no haste. In this unhurried conversation, the clinician is able to appreciate the patient's situation in high definition, in all of its complexities, biology and its biography, and to respond to that situation in a solution that is co-created with the patient, a solution that needs to make sense intellectually, emotionally, and practically. An unhurried conversation is the trick that the healthcare systems that truly care have to muster, because it is through unhurried conversations that we can see care happen. But then COVID happened. And COVID introduced itself as a wedge, not the virus itself alone, but the responses of industrialized healthcare to the threat of COVID. And this has had tremendous implications to the process of diagnosis. What is diagnosis? Well, it comes from the Greek. Dia, which means different, and gnosis to know. It is to know what is different, to be able to distinguish and discriminate what is new about this patient. Well, this requires us to understand what is usual, what is normal, and to understand what is different today. This requires us to notice to diagnose what is the situation really, and what aspect of that situation really demands our action, and what are the actions that the situation demands. A process in which we iterate until we have a deeper and joint understanding of what's wrong and what the solution might be. A solution that we hope will make intellectual sense. In other words, it will match the nature of the problem and it will be scientific. It will make emotional sense. It will feel like the right thing to do. And it will make practical sense in that the solution can be implemented and embedded in the routines and lives of the patient. That is, we should be able to notice and respond. So when COVID comes around, it introduces, again, itself and the policies of COVID as a wedge between patient and clinician, breaking down the process of noticing and responding, then the processes of care. How? We all heard that early on, the message was, we'll be okay, unless you're an older person with chronic conditions. Then, you are in trouble. What my patients, I'm a clinician that takes care of people with diabetes, what my patients heard caused them tremendous distress. They were not safe. They were at risk. They were exposed. They could have severe disease and die. Healthcare then said, our offices are closed. And our distressed patients found that they had a denial of service. They couldn't get the care they need because the offices were closed. The priority is the pandemic. Once again, our patients with chronic conditions who needed to be seen, needed to be noticed, and needed a response, found that their situation, their care had to be delayed because the priority was to respond to the pandemic. Telehealth is the new default. It helps us take care of you while we protect ourselves. But telehealth creates the illusion of closeness, that we can be seeing each other across a screen and feel like we might be touching each other. And when that is not necessarily the case, there is a distance that we wish eagerly to, a gap that we wish eagerly to close, a distance that must be traversed. But no, it's just telehealth. It's just a phone call or a video visit. And you cannot see me and you cannot respond to me. Most affected are the most vulnerable. Well, we've heard this before, and this introduces discrimination in the way people experience outcomes, with those who already had the most care still benefiting from access, while those who struggle to access care now finding it even more difficult. And that distress, well, that distress actually counted for more to those people who perhaps, because of longstanding racism and injustice, found themselves not only unable to seek care, but also at an increased risk of suffering from the deadly consequences of the virus. We don't have protection for caregivers. Well, this meant that people who were breathless had to be breathless without a hand to hold, had to struggle alone to catch air, to catch oxygen, and found themselves in many cases away from the caregivers that knew them and knew what their needs were when they needed them the most. This caused desolation, isolation, and dying alone. We did the best we could, healthcare says, but then that best meant disability, and increasingly we are hearing premature death for people who otherwise would have lived through this time, but because of the policies in response to COVID, now experience untimely death. We're back in business, we said, in healthcare. But the business that we're back in is the business to recover our financial targets, which often meant focusing on procedures. Once again, my patients, the patients with chronic conditions, could not get the access they need. They could not get in. They could not be seen. They could not be noticed. They could not be responded to. So why would industrial healthcare, whose fundamental mission is to care, allegedly, cause so much cruelty, so much suffering in its response to COVID? And I think it is, there might be a number of reasons and motives, and they may vary from place to place. But let me tell you one potential cause for this behavior. One potential reason why we couldn't really care well for Maria Luisa during this pandemic. And that reason I want to propose to you is greed. Our organizations, many of which are nonprofits, have focused on their mission and realized that in order to achieve it, they need resources. They need money, they need time, they need personnel, they need equipment, they need infrastructure. Without those resources, there will be no mission. But all these organizations invariably begin to feel the need to obtain more resources in order to achieve more of their mission, expand their market share. And the way they make this money is through patient care. So patient care goes from being the end of the organization, the objective of the organization, to become the means by which the organization achieves its organizational and financial targets. The patient as an ATM. Greed also works in a different way. By having if the greed is optimized by promoting the consumption of healthcare, the patients are seduced into getting the new treatments, buying the new procedure, getting more of it. We have seen in the care of VIPs how those individuals got different care, more care, making it desirable to others. But those others are listening in a different tune. Because when the greed is satisfied by reducing the consumption of healthcare, for instance, when payers don't have to disburse as much to support care, then patients will hear that they should choose wisely, they shouldn't buy, that less is more. And so greed traps patients between the seduction and the frustration. We did this study in 2019 where we looked at the 100 most influential people in healthcare. And one of the things you can see that is in the last 10 years, there's been a substantial shift from in the past having industrial agents, academics, advocates, and elected officials share the influence on how where healthcare was going. In the last decade, the fundamental influence in the direction and content of care is provided by CEOs. CEOs of hospitals, pharmaceutical companies, insurance companies. They are influencing what healthcare does, and the ethics of care is different from the ethics of business. This cartoon demonstrates this, where we have a board here, and the chairman of the board is saying, granted, it would save countless lives, but to what end? And this might be a funny cartoon until you then notice that during COVID, the Secretary of Health and Human Services was asked in Congress, would you make sure that the vaccine for the coronavirus will be available to everyone, affordable by everyone? And he said, I cannot promise you that, because in order for the vaccine to exist, there needs to be these incentives for these companies for them to actually do the work to get the vaccine. You can easily imagine the companies agreeing with Secretary Azar and saying, yeah, I mean, we know it could save countless lives, but to what end? So what is the way forward? The way forward is to work towards a system that is not based on greed, but rather based on solidarity. Solidarity that may have come across to you as poetry until you realize that we've witnessed a massive amount of universal solidarity in response to COVID. Just as healthcare was struggling to take care of people and instead was advancing its business objectives, the communities reach out to its members. People stayed indoors for long periods of time, suspended their economic activities to advance the health of everyone. We have witnessed in this generation, in this time, in this year, the largest manifestation of universal solidarity ever seen before. This fills me with hope. We need professionals that are not bound simply by regulations and incentives, which are necessary, but in fact are driven by their integrity. If they want to be treated like professionals, it is absolutely essential that they start being guided by the values of their profession and not simply by playing by regulatory rules or by following the incentives like those little rats in the psychology experiment looking for the cheese. We don't want healthcare to be simply efficient, do more with less. We want healthcare to be elegant, you know, like a ballerina, like a gymnast that is able to not spend movement and energy and effort in wasteful ways, but also to move in ways that are consistent with the rhythm of the music. No haste, no waste. We want healthcare that is capable of taking care of this patient, not of patients like this, and that is capable of doing so in the context of relationships that are not simply made up of a series of business transactions, but rather relationships that lead to love. So this brings me to the end. We have to think about care in a number of ways, but I'm going to show you 3 cathedrals. The first one is by Rodin. It shows 2 hands coming together, each hand from a different person, the fingertips about to touch each other. The palms of the hands are the walls of the cathedral, the fingers, the spires that reach to the sky. To make that sculpture, Rodin had to remove what was in between those hands, get rid of the extra rock, create the space for care. And I think a lot of the work that this community has to do is to make sure that there are no distractions or barriers or frictions between those called to care and those who benefit from those caregivers. We need to work towards care by removing the barriers to care. The second image is from the south of Spain, where communities compete in building these enormous human pyramids. Everybody participates regardless of their age, gender, physical fitness, and you can see a child going up there. And together they make these incredible human pyramids. It's important to recognize that when we think about care, that care is actually a commons. It's a resource that we should all be able to access from each other, because we have to recognize that suffering is fundamentally human, but not all suffering requires a medical response. But healthcare, industrial healthcare has privatized the space of care and slowly made sure that community could not respond to the levels of suffering that are a common part of the human experience. We have to recognize that care is a human trait, that not all care, therefore, must be professional. And I think one thing that COVID has made very clear, unless somebody was not paying attention, is that individualism is a delusion. What is most clear now is that we are as vulnerable as the most vulnerable member of our community. Community is real, and we've all seen it firsthand. And this is the last image. This is the Sagrada Familia in Barcelona, and it's always under construction. Every generation since the beginning have been contributing to the beauty of this church. The first architect was fired. The second one was crazy and made this incredibly innovative design that generation after generation of Spaniards have been building. Some generations killed each other in the middle of a civil war, and the next one picked it up and kept going, and each one has been adding their touch of beauty to it. And I think that my call for a patient revolution may have this timeline. May be that we will never see what the end result will be. We may never experience what careful and kind care for all might be, but we need to start today if we want the future generations to benefit from it. Is this simply a hopeful utopia? Well, let's break that down. What do we mean by hope? Well, an optimist is someone who thinks that the future will be better, whether I do something about it or not. But hope is slightly different. Hope recognizes that there is only a small chance that the future will be better, but we can improve that chance. We can improve the likelihood of that will be realized by what we do today. So I think this is a hopeful utopia. But why do we need utopias? Well, utopia, that question of why we need utopias was asked of a Argentinian filmmaker, and he responded that we needed utopias. And the student then asked that question, said, well, why do we need them? And he said, well, we need them like the horizon. When you take 5 steps towards the horizon takes 5 steps back. When you take 10 steps towards the horizon takes 10 steps back. If you take 100 steps towards the horizon will take 100 steps back. So why do we need utopias? For that, for walking. And I think it is time for us to walk together towards a future of careful and kind care for all. Thank you very much for your attention.
I would like to go ahead and introduce our next speakers, David Myers and Marjorie Robertson. So David is a SIDM board member. He's a former head of emergency medicine in Baltimore, and he's also a recent graduate with a master's in bioethics. Marjorie is a life coach in Atlanta. She has a doctorate in business. She's a long-haul COVID patient and a member of the Survivor Corps and other long COVID patient support groups. Marjorie's initial COVID misdiagnosis and the consequences it has had for her will be the topic of her and David's conversation. So David and Marjorie, thank you for joining us.
Hello, everyone. My name is David Myers. I'm an emergency physician and member of the board of directors of the Society to Improve Diagnosis in Medicine. I have been an emergency physician for almost 40 years, and in my time, of course, have seen many patients and many misdiagnoses. As a medical director, I was responsible for a lot of emergency physicians and their work. I also have worked in the risk management field as well as in claims management for a large physician practice management company where I was responsible for 7,000 physicians and about 6 million patients a year in the risk management and claims management area. And I've been concerned and interested in how to improve diagnostic processes and physicians' abilities in diagnosis for many years. With me today is Dr. Marjorie Roberts, who has a not so unique experience, unfortunately. Marjorie acquired COVID-19 several months ago and went through a diagnostic journey that we thought was important for our audience here at the conference to hear. So I will, without further ado, introduce Marjorie, and she can tell us a little bit about herself, and then her story is so compelling and interesting that we'll let her go forward from there and tell us what's been going on with her for these past several months. Marjorie?
Good morning, and thank you. Thank you so much. I'm Dr. Marjorie Robertson. I currently reside in Atlanta, Georgia. And my COVID journey began back on March 26th. It was just a normal day for me. And I was just returning home from walking in my complex from the mailbox. And I kind of stumbled, and I really didn't think too much of it. And I came home, and I just wasn't feeling well. I just was feeling different. But I didn't think in a million years, I didn't think that COVID-19 had anything to do with it. So as the evening progressed, I began to feel different. I began to lose energy. I just couldn't get my thoughts together, and my mind was just rattled. And again, I didn't think anything of it. So I took a little over-the-counter medication, and I kind of laid around that afternoon thinking that it would pass. But as the night progressed, I began to feel so different, and so many things started to go on with my body, and I just started to feel weirdness, just a weirdness. And a sort of exhaustion. And as the evening progressed, I just started feeling like I had never felt before, and I couldn't put my finger on it. But again, I didn't think for a minute that it was COVID-19. But later on that evening, I just couldn't do anything. My energy level, it was less like draining fast, and I just couldn't do anything but lay down. And later into the night, I just started to just get all kind of weirdness going on, and I had a diarrhea, and I had a headache, and I just wasn't feeling good. But again, I didn't think anything of it. So as the days progressed, I began to get sicker, and I started to have all these different things go on with my body. But what was weird about it, they would all start happening at the same time. So I would have like a headache, and again, I would have diarrhea. And then my breathing became really labored, and I just couldn't catch my breath. And then I would start to throwing up. And then I started to have like these crazy nightmares over the course of the next few days. And then it got to the point where I couldn't even do anything for myself. I couldn't get out of the bed. I couldn't really eat, but I had to force myself to eat, and it wouldn't stay down. I had a headache. I had chills. I just had so many different things going on with my body that had all began on March 26th. So by April the 5th, I was so very sick until they had to take me to the emergency room, and I didn't want to go. I was a bit frightened because it was early on in the COVID game, and they were saying if you didn't have to go to the hospital, then don't. But like I said, by April 5th, I was so sick and so many things were going on with my body until it was scary. So my husband took me to the emergency room, and when we got to the emergency room at the hospital, it was like nobody could go in with me. You know, I was on my own, so it was sort of like getting dropped off. So my husband dropped me off, and I made it into the triage area of the hospital. And as I began to tell them my symptoms, everybody's attitude had changed, you know. At that point, it wasn't in the bedside manner. It was just a scary atmosphere because everybody had on PPE gear, and they had a special section of the hospital for people like myself who were experiencing all these different symptoms. So finally, they got me situated and hooked me up to IV because I was dehydrated and I was so disorientated and everything was going on, and they were asking me questions, and they took a EKG, they did a lung x-ray, and they did all these tests, and a couple of hours later, they came and they said that I had to take the COVID test. Now, I had seen pictures of that COVID test. I had seen the what it looked like, but to see it up close and personal, that took me to a whole nother level of scariness. And there wasn't any bedside manner at that point in the emergency room. It was just like nobody really wanted to talk to you outside of asking you the questions that they had to ask you, but they were just treating me different. And I sat there and they come in and the test was conducted. And at that time, I didn't know any better because I was scared. And the nurse kind of shoved this long contraption, sort of like a Q-tip up one nostril of my nose, and, you know, said, okay, we'll get back to you with the results. So a couple of hours later, after laying there in this room, it was cold in there, the atmosphere was cold, I was scared, didn't have anybody around me. They came in and they said, well, this test is negative and you have an upper respiratory infection. There's really nothing we can give you, so you got to go home and stay hydrated and fight it out. So at that point in time, that night, I was thankful. I was ecstatic, and my husband came and got me and brought me home, and you know, we talked about it, and I said, okay, they said I didn't have this COVID and that I'll be okay. So I continued to get sicker. It just from April 5th until April 27th, I was sick. I was just really sick. I was sicker than I had ever been in my life, and I didn't know what was wrong with me, and my family was scared, and nobody knew, and they had told me I didn't have it, so I didn't think I did, but I had never been so sick in all my life. I couldn't do anything for myself. I couldn't
Marjorie,
breathe. Yes?
Can I interrupt for 1 second and ask, when you say you got sicker, was it worsening of the symptoms that you started with, or were you getting additional symptoms that were showing up that you hadn't had before?
Yes, sir. I was dealing with the symptoms that I had, but they went to a whole nother level. And then I started to have other symptoms added on to the ones that I was already having. So my breathing I couldn't breathe. I couldn't breathe at times. I was panting like a dog. The diarrhea was out of control, and I wasn't able to eat much. I was like having soup and stuff, but I couldn't keep it down. The headaches were intense, and the pain in my body and the pains in my legs was crazy. So I started to put on my husband's compression socks, because he had always talked about them, and so I put them on to kind of help with my legs, and I would get cold, then I would get hot, and then I would start sweating. And then I was having like the nightmares, which were intensified. So all of the symptoms that I was having, they were just going to a whole nother level. It was just like, it wasn't a normal headache. It wasn't normal diarrhea. My breathing was so labored, and I was so weak, and the exhaustion was so bad, I couldn't get out of the bed. My husband would have to help me from point A to point B, and I couldn't do anything. I couldn't talk really, because my voice was so different, and I would get tired really quick, and the hoarseness was really quick. It was just everything. It was just on a whole different level. So again, they did all those tests on April 27. They told me basically to go home. You still have an upper respiratory infection. Nothing's wrong with you. So during that time, they had told me to contact my primary physician, which I did. She was of no help. She had been my doctor for 5 years, but she told me basically to watch Lifetime movies and to watch feel-good movies and to work jigsaw puzzles, because there was nothing wrong with me, and I was mimicking what I was seeing on television. And I was begging her to help me, because I really thought I was going to die. And I had that conversation with my daughter, and I had made sure that everything was in order. She knew where my health insurance, my information for my insurance was, my living will was intact. Everything was intact. So I thought I was going to die. I really thought I was going to die, and nobody was willing to help me. So during that time, I had joined some survivor groups, some COVID-19 survivor groups, because on my days that I could function somewhat, I wanted to find help. So in those groups, I was able to find people like myself who were going through the same thing. Meanwhile, I was sick. I was sicker than I had ever been, so I had to go back to the emergency room again. But prior to going back to the emergency room for the third time, I was looking for a new doctor. I had found a new doctor, and she wanted all those reports. So there were 3 different emergency room reports that she went through, and she told me that she wanted me to take a blood test so that she could see for herself, and we could get some sense of mind of what was going on. So through her blood test and through all the workup and through everything that she done, she let me know that that test that I had taken on April 5th was not true, that it was false, that I did have COVID, that my body was out of whack, my numbers was out of whack, everything was thrown off. So she began to work with me, and she got me connected to a lung specialist, and they did a procedure where they went down my lungs, and they saw that it was nodules that had formed in my lungs, and there was scar tissue going on in my lungs, and everything was just messed up in my lungs. And so they did a biopsy to make sure that those nodules were not cancerous, but they're still there. So now this week, just this week, I had to have another CT scan in my lungs, my abdomen, and my liver. And I also have a sleep test scheduled. And it's just so many things that's going on in my body. It's just so many things that's just going on. So many COVID-19 has done damage. And my life is not the same. I just had taken my certification back in November to become a life coach and to start my own business. That was just in November. In December, I got a little part-time job working in a hospital, managing a gift shop so that I could have the money to start my business. That was in December. In March, COVID-19 struck. And now here I am, October, still dealing with issues that came about in March. And because my primary doctor of 5 years wasn't willing to help me back in March and in April and May, until I didn't get the new doctor until June, all that they could have been done and everything that could have been done if somebody had paid attention to me wasn't done. So now here it is, October. My life has changed. I can't go anywhere by myself. I can't do the things that I was doing prior to just March 25th. I can't do any of those things. I can't go outside by myself. I can't walk far. I can only, thank God, I can walk to the mailbox, but I can't go outside of my complex. I can't do anything without my husband and my daughter being with me, because my body, I don't know when I'm going to crash. I don't know what's going to happen. The shortness of breath comes when it wants to. When I get a headache, it's not a regular headache. When I get anything that goes on right away, I get upset. I get nervous. You know, I'm working with a therapist, and she's really good. So with what she's working with me on and the things that I learned in doing my coaching to becoming a certification, I now have to do these things to myself. I'm my best patient, because I have to motivate myself. I have to keep myself going. I have to push myself, because doing all of this, I had a friend to die. My friend died from COVID. My friend that I had been my friend for over 30 years. So prior to Gary dying, I was angry. I was mad. I was angry at the person who made me sick. I know somebody literally made me sick back in March. But then after Gary died, my whole attitude changed, because it was at that point then that I realized that my life had been spared. I was spared. I was one of the lucky ones. I wasn't one of the thousands that was in a hospital on a ventilator with my family staring at me from the other side of the glass. So that made me step up my game. I had to fight. Because I have one daughter. My daughter is my very best friend. I gave birth to my very best friend. I couldn't leave her. I had to fight. I had no choice. I had to fight, because she's my world. That's my world. So I began to fight. I began to pray harder. I began to do everything that I could do. I got my church involved. I started going public with my story. I started to share my story. And when people in the African community wanted me to be quiet, they was like, don't tell it. You know, don't talk about it. You're a doctor. You have a title. You have all these things. You're successful. And I was like, COVID didn't care. COVID didn't care that I had a PhD. COVID didn't care that I had a doctorate. COVID didn't care where I lived, what we drove. COVID didn't care about none of those things. And I got angry again, because it's like, you want me to treat this thing like a dirty little family secret. You want me to be quiet. I will not be quiet. This thing is killing people. This COVID is ruthless. COVID does not care. The level play is a level playing field when it comes to COVID. COVID don't care if you black, you white, you Asian, you whatever. COVID does not care. It goes after anybody. Class didn't mean anything. The fact that I went to school for 9 years, it meant nothing. It meant absolutely nothing. Nothing mattered to COVID. So that's why I became the fight. And then when I saw people like myself in my groups who were going through the same thing, who were getting gaslit, who were getting told you were crazy, who doctors was prescribing all kind of medication that alter your mind. No, I didn't take any of those drugs. When my first primary doctor tried to get me to take those pills and try to get me to think I was stressed, I told her, no, I was a single parent. I know stress. I know stress. I went to school for 9 years. I knew stress. That wasn't stress. That was my body being destroyed. I had to fight. I'm still fighting. I fight every day. I fight. I get up. I pray myself up. I motivate people. I done numerous. I done all kinds of media to help share my story. I'm not going to be quiet. I'm not going to be quiet, and I'm not going to say that I didn't have it. Yes, I had it of no fault of my own. We didn't have COVID. We didn't say sign up for this. We didn't volunteer for this. It happened. It happened. It happened to me. It happened to me. I was doing everything that I knew to do prior. It was just a couple of weeks into March, but I was doing everything because I was living my life like it was golden. This is my year. In a couple of days, with the help of the Lord, I will be 60 years old. This was my time. Yeah. This was my time. This was my time. I had done everything that society say you're supposed to do. I'd done all that. And COVID did not care. My life has changed. It's changed. I don't know from one day to the next how I'm going to feel. But on my days that I do, when I have any energy, I fight. I'm in survival corps. I'm in long haulers. We're doing big things. We're doing big things. And this has just been in 6 or 7 months. Because on March 25th, I was fine. I was fine. I was fine.
We can certainly see what a huge impact this has had on your life. And also the fact that you are a fighter. It comes through so clearly in the way you tell your story and the actions that you've taken. I wonder if I could ask a couple questions just about your experience that I'd like to hear a little bit more about. For example, you talked about getting involved with some support groups. Yes. Outside. I gather you were not given any specific treatment for COVID. You were never hospitalized. You weren't on a ventilator, and you were never given any specific treatment.
No.
And then you might have received treatment for some of the other side conditions that you had, and I guess you're still being worked up to see if there's anything more progressing or going on with the disease. Is that correct?
Yes, sir.
But I know that you mentioned the Survivor Corps and a couple of other support groups. Can you tell us the role that they've played in helping you and in what you've done to get your story out among those people and how that has benefited them and the impact on you?
Yes, those groups have saved my life. Like I said, back in March, in April, and into May, those groups saved my life because I was able to connect with people like myself from all over the world, and our stories were the same. They had been gaslit. They weren't receiving any treatment, and they just treated us different. I put my story out there, and the response I got from my story, people were like, "This is me," and I was very public, and I would do a lot of videos and post on my Facebook page, and people would see that. And in my groups, I would tell my story, and we talked about stuff, and we talked about our families. We talked about the good, the bad, the ugly, and we could tell our truths and talk about anything and everything, and nothing is off limits. I'm not embarrassed. I'm not humiliated, because when you do put yourself out there and people do find out that you have COVID, everybody's not nice. Yeah. I've been called, things that, and I've been, you're faking, and how much did they pay you, and you're a good actor, and you're such a little black sheep, mean things. But when I get those kind of response right away, I pray for them people, because even though I have COVID-19, I got peace of mind with it. So a person or people who say mean things to us or say mean things about us, that lets me know that they don't have peace. They're not where we are. So that's what I do. That's what I strive for. I get everybody to, you know what, be at peace. You know, first of all, thank God that God spared our life. And that's the foundation in which I have built. So those groups really have saved my life. And I don't know where I would be without those people.
Let me ask you this. Are you still seeing the new primary care doctor that you started seeing in, was it May or June?
In June, yes.
And is that doctor the main person taking care of you, or are you seeing a lot of specialists in the process? What's your situation now in that regard?
Now, my primary physician and my lung doctor and my therapist, they're my main team, and they communicate with each other because they you know, for whatever reason, they believe me, and they are determined to help me get some sense of, you know, to get some of my life back. You know, nobody made no promises because they were honest with me. You know, this is new. This is new to the medical field, and I think we're able to build this bond because they're honest with me. They ask me questions. We talk about it, you know, and they, you know, and both of them said, if we don't know the answer, we'll try to help you. So they know that, you know, we're all on one accord. So it's that I have that team of three that they got me. They got my back, and they got me, and they pushing me forward. And but I had to fight like all get out to get to that point, because if I had stuck with my first doctor, we wouldn't even be having this conversation, because I don't even want to think about what could have happened if I didn't speak up and fight for myself, Doc.
What you're saying now is very important, and I want to particularly emphasize a couple things you said, which had to do with being honest and transparent and listening, showing respect to what you're reporting, and working with you to try to understand it better. I think we'll have a lot of physicians and people in healthcare in our audience, as well as a lot of patients. And one of the messages that we try to promote through the society has to do with respecting patients and being honest and open about whether the physician knows what's going on or not, being able to say, I'm not sure, but I'm willing to work with you to find out what is going on. And if we can't figure it out today, we'll stick together over time and see what can be learned about the problem so that we can give you the kind of care that you're going to need. So yes. I would just ask you to reflect once more on what would you have wanted your original physician to do differently that you think might have helped you, maybe not to avoid all the complications of the disease, because the disease, as you explained, has a mind of its own and, you know, causes a lot of different symptoms and signs. But what would have been more helpful on the part of your original physician back at the beginning?
I think if she had stuck to the plan, because she had been my physician for 5 years, because I moved here from Philadelphia after 31 years of having a solid life. And one of the first things I done when I moved to Atlanta was to find me a new doctor, because that's what I do. You know, that's what we do. I've always been in tune with my body. I was always raised, you know, to know I know my body. So the first thing I done was to align myself with a new doctor, and I thought that she was that was because she had been my doctor for 5 years. So when she gaslit me, and she told me that I was making this up and that I should just watch Lifetime movies and take all these different medications to make me happy, I was disappointed. I was hurt, because I thought she was cool like that, because we had built such a good rapport. And so I thought that she knew me. I thought that she knew my body. I thought she knew my mind. I thought in 5 years, you know somebody. That's not a lifetime, but that's a long time, because I had been to her and she knew me, and she knew that, you know, I had one thing going on. I had high blood pressure. but I was on medication for that. That was under control. Other than that, I was fine. So she knew I wasn't a person who was running back and forth, or I have my leg hurt, my eye hurt, this hurt, that hurt. That wasn't me. So I think that if she had been honest with me and told me, I don't know, or let me get somebody in on this, or let me recommend another colleague of mine, instead of saying, go watch Lifetime movies and take medication to calm me down, that was so hurtful. So I really think that she could have approached it a little differently. But the fact that she didn't, you know, like everybody else, I'm not mad with her. I didn't bash her name. I would never do that. I would never, ever put her out there. But what I did was I prayed for her, because God knows who came behind me and had those same symptoms. And what about people who didn't have the health insurance? You know, it was just so many what ifs, but I can't go back to those. But like I said, I'm just thankful that I have that my new doctor from day one. From day one, she told me, she said, I'm going to go through all of these reports with a fine-tooth comb, and, you know, and after she was like, something's not right. You know, this is not adding up. And she didn't say, I'm sorry.
I was going to say, did you ever have contact with your original doctor after you switched doctors, or did you ever tell her that you were ultimately diagnosed with COVID?
No, because what we did at the same time, all those reports were being compiled and everything was coming together. My daughter just suggested that I go old school. So what we did, my daughter printed out every single report. She printed it out, and we put it in an envelope, and we took it to my old doctor's office. We took it there. So she couldn't say that, you know, I didn't see it or I didn't read, because she had it in print. She had it in print, and I was still holding out that little bit of hope that she would be the person that I had come to respect and admire as a human being. So when she never responded, she never said, I got him. She never responded, but I know in my heart she got him, because everybody at her office knew me. You know, they was like, there go the girl with the smile, here she go. So everybody knew me. So I know that her staff made sure that she got the printed copies of those 3 different reports from the emergency room visits. I know that she got it, but no, I haven't had any contact with her, and I won't. I won't. I'm not. That's a closed chapter of my life, because like I say, I'm blessed, and I have people who believe in me, and I have a phenomenal support group now, and I have a doctor that cares. I have a doctor that did not let COVID take away her bedside manner, and she is a phenomenal human being, because she didn't know me, but she knew me, and now she knows me.
Well, it's a very satisfying end in some ways to this long journey that you've been through with this disease. And although you're not out of the woods yet, it certainly sounds like you're in a better situation now, at least with your physician, who is taking care of you the way you wanted to be taken care of. And our hope is that, you know, you'll continue to make progress, and at some point you'll be free of all these symptoms, and your life will get back to normal, and you'll be able to resume your career. I would point out one thing. Your situation is especially dramatic, I think, but there are many, many patients who go through similar, if maybe not as severe an experience, who have symptoms and signs that are not recognized to fit in with any pattern of a known condition. And there's even a term for this called medically unexplained symptoms. And some people, and it happens more frequently with women than men, go through long periods where they are symptomatic and their doctors can't explain it. They go doctor shopping thinking another doctor will be able to explain it, and they go for months or years even before the disease clarifies itself, and it becomes, you know, all the tests may have been normal, but at some point something will change after months or years, and the diagnosis becomes clear. And in the meantime, then they've been referred to watch Lifetime movies or get psychological care and things like that. So it's a very tough problem to figure out when a disease causes tremendous symptoms and pain for the patient, but doesn't have tests that are reliable at various stages of the disease. So I think there are a lot of lessons here for physicians and for patients. The resources you brought to bear and the work that you're doing to help others, I think, is really, you deserve a tremendous amount of credit for doing that in spite of all of the pain and suffering that you've had over this time.
Thank you so much, Marjorie and David, for sharing that powerful story, and David, for your insightful questions. We are ready for the panel. So I want to, introduce our final new person for the, hang on a second, I've lost my video. Final new person, who is Io Dolka, who is going to be moderating the panel. Io is she is a patient, longtime patient advocate. She's a member of our patient engagement committee at SIDM, and she has turned her experience into a profession. First as co-founder of WASHA, Washington State Organization of Professional Patient Advocates, and now as the founder and chief care advocate of Gray Zone, which is a medical advocacy company that specializes in helping difficult to diagnose patients get a diagnosis and manage their chronic conditions. So Io is going to open the panel by talking just a little bit about her experience as a patient and a patient advocate, and how it ties into what we've heard this evening. And then she's going to set the stage for our speaker discussion. So I just want to remind you, you can submit your questions to Io or to any of the panel members by putting them in the chat, and they will be collected and passed on to the panel by our able patient engagement director, Sue Schrant, who's working diligently behind the scenes. So Io, take it away.
Thank you, Helen, very much. Welcome back, everyone, and thank you for being here for the Q&A section. This is the final section, as Helen mentioned. And as she said, please post any new questions you have in the chat box at the bottom of your screen. We will be starting with a few questions we already have, and then select more as they come through. Before we begin, I would like to also thank SIDM for the opportunity to be moderating this panel of exceptional safety experts, as you saw, and empowered patients like Marjorie. As a rare disease patient myself, and as a professional patient advocate who helps patients navigate the healthcare system every day, I have seen firsthand a lot of the issues being raised by the speakers. When I got sick myself after being a very active and young professional in biotechnology business, it was difficult for my doctors to figure out what was wrong with me. As I slowly became homebound and then bedbound, I saw my life slip away from my hands without my doctors being able to figure out what was causing this catastrophic turn of events. When difficulties started to pile up, I faced doctors dismissing me, blaming me, not trusting me, even running full-scale drug testing on me without my knowledge. I saw what I called the ugly face of medicine. It took a tremendous amount of effort to learn to speak up for myself and to eventually seek and find a caring, knowledgeable, and willing team of excellent physicians who saw me as an expert in my own body. Together, we were able to successfully co-produce several diagnoses of rare and chronic diseases and slowly get me off my bed, out of the house, and back into a productive and fulfilling life. That's when I saw what I call the healing face of medicine, the kind and compassionate providers who took the time needed to care for me and help me regain back my life. Patients find themselves often in a position where they need to advocate for themselves because clinicians dismiss their symptoms. Access to care is a significant issue for millions of people, and so are the conscious and unconscious biases that were addressed previously. That's why I think discussions like this one today that we're having, patients and medical experts coexist, are vital to raising awareness of the issue on both sides and forming the framework on which both patients and providers can together work to improve medical care today. So that was something I wanted to tell about my story in the beginning, and now we're just going to go into the questions. We're going to start with a question on kindness, humility, and unheard conversations. Listening to everyone's presentation during this panel, there's a common theme of a need for kindness, humility, and compassion to be able to receive the right care and improve diagnosis. Another element that helps the diagnostic process is the value of unhurried conversations in noticing and responding to what is happening to the patient, as Dr. Montori said. Dr. Wyatt also mentioned Dr. Venable's advice to him as a young physician to respect the knowledge of the patient and listen carefully, as the patient will tell you what's wrong, will in essence give you the diagnosis themselves. So Ron, I'd like to start with you. What do you think stands in the way today from having this type of experience, the kind and unheard conversation?
Yeah, sure. Thank you, Io, for that and the question. And thank you for, and I'll start this way, taking charge. So I really am convinced that a major issue with my profession, my colleagues, is fear. And part of that fear is what I don't know, or fear that the person I'm caring for thinks I don't know, or fear that I will somehow lose some of my power, as that power distance between me and that patient may be a comfortable place. So then I would say, as we move forward, we have to replace the fear. We have to have the courage as caregivers, to your point, to co-produce a diagnosis and a plan in a partnership. And that's what I came to learn from Dr. Venable, and again, over the years from Dr. Sapara. So I would say we have to move away from that fear and be more courageous. There's a lot of power in the medical profession. I would say collectively, we need to become, and I'll just say as physicians, we need to become abolitionists. That gets back kind of to that movement and revolution that Victor talks about. We need to be abolitionists for people that trust us, for people that come to us as seeking our care and our knowledge. So I'll stop there, but that's what I believe. Thank you.
Thank you. I think that's very powerful. And I think fear is what a lot of patients sometimes feel is in the room, but it's very hard to talk about. Victor, I'd like to ask you in the same vein here, what do you think patients can do to increase the chances of receiving the good type of care?
I find it very challenging to place the onus on patients to extract from a system that has forgotten or deprioritized care, extract from that system care. I think we have to recognize that when patients encounter clinicians, many of those clinicians, as I expressed in my presentation, find themselves working in very adverse conditions. Patients and clinicians are, I think, natural allies in the fight, and a non-violent fight. It's very important to notice this in this environment, in a non-violent fight, to reclaim care as the fundamental reason patients and clinicians come together. To expect clinicians to extract that puts them in the position to be traumatized again, if they've been traumatized in their first encounter, by virtue of them being labeled as difficult patients, or patients that perhaps the clinician doesn't have the time to return the phone call or address, or that the administration would not like to deal with them, and in fact, maybe offer a visit with a lawyer rather than actually a frank discussion about how to improve process of care. And another point for those patients who are participating here, when I talk to rooms full of clinicians and ask them, why is it that they haven't stood up for themselves and for their patients for care against some of the policies that limit their ability to care, the answer I get is that they can't, is that they have no power. So it's fascinating to hear patients say, well, clinicians have all the power. And then to talk to a group of clinicians and find the clinicians completely unempowered. And so I think patients and clinicians find themselves on the same line of the fight. And they're partners in the fight for reclaiming careful and kind care as a fundamental reason why we have a healthcare system. It's not to bring profit and industrial solutions. It is to care. And the whole apparatus of it should be held accountable to their ability to support patients and clinicians in that caring possibility. One more thing is we are now probably a couple of generations in where the clinicians that are being recruited, the medical students, the nursing students, the people that are being brought into healthcare, they're being recruited and attracted to healthcare. What they know about healthcare is that healthcare is that place where the business of healthcare takes place. And I'm worried that we will have generations of clinicians that have entered healthcare for the wrong reasons. And we will have to rescue them and reclaim them for the beautiful, beautiful job of caring for and about each other with patients.
Yeah, thank you. Actually, there's a lot to think about in what you're saying, both about the future, but also about the fact that patients and physicians are ultimately on the same side. And I don't think that either ones recognize this very often, at least in my experience. Let's move now into a very important topic that Marjorie talked a lot about, which is believing the patient. I have seen what Marjorie and the Lieutenant Governor discussed regarding providers not believing their patients when they tell them what's wrong. People report that again and again, especially in the chronic disease and in the medically unexplained symptoms community that David Myers alluded to before. Some providers are dismissive consciously, some are unconsciously. Others suggest that patient symptoms are all in their heads or they are psychosomatic, as one of our attendees noted in the chat box, or they're simply of psychiatric nature. So Ron, I'd like to start with you. Why do you think this is happening? Is it again the fear, or is something else playing a role in this situation?
Yeah, so certainly we talked about the fear, having taught in medical school, I would also say we need to look at how medical students and trainees are trained. What does that training look like? And we know that curricula are so structured, but we really need to get into that part of this. So that's going upstream so that medical students can learn the right approaches to patients, to learn how to listen, to learn how to be humble, to learn how to communicate, to learn how to recognize the things that are most important or matter most to that person or that family that's sitting in front of you. Again, as a friend said to me, in this profession, a lot of times we have this shiny gold watch that we want to tell every patient, look at my shiny gold watch. That represents all my expert knowledge. And I think what we need to learn how to do in training is keep your shiny gold watch in your pocket until that person or family asks you what time it is. And then you pull it out and you tell them what time it is. And based on your knowledge at that point. And then you can step forward from there. But if we continue to think that we can train medical students and residents to have this high degree of decision-making autonomy without partnering with people, we will do more harm than good, which is antithetical to what we need to be doing in health and healthcare. Being humble, again, listening, having the courage, and I'll say one more thing about courage. The root word for courage is corde. Corde is heart. So when students and trainees say, this stuff is hard stuff, and I just tell them, no, this is heart stuff. That's what courage is. So we can bring that kind of heart stuff, that heart work to people, to the families, to the communities. We can partner, and that's the revolution. And we can do that. And we can abolish all of this fear and mistrust and distrust and emotion that has evolved over the years of this industrialized, fast-paced, out-of-the-box, off-the-shelf type of medicine. And I'll finish by saying something that Victor alluded to. My concern in this is that with industrialized medicine, we have gone from a movement, as another person said, to a business. And a business at some points become a racket. So that gets into the greed that Victor talked about. So if we learn how to partner, how to engage with, and to Victor's point, how to engage and move to a higher level, which would be that activation level, then I believe we have that revolution that Victor's talked about. Thank you.
Yeah, thank you. I like the shiny watch, and I think people on the chat box are posting the same thing. It's a nice metaphor to keep in mind. I think one of the problems here when you're having people not believing you as a patient is you feel helpless. You really feel very, very helpless. So I'm wondering, what can we do to change this? And Marjorie, I'd like to hear from your point of view. What did you do in your case? I mean, you talked about changing doctors, but what else? What other tools in your toolbox did you use? And then to hear from Victor's experience as a physician, what is there for patients, if there is anything, to really do there?
For me, I just fought. I just really fought. I was tenacious in getting it done. I knew my life depended on it. And like I said, you know, I have one daughter and I had to do everything that I could do to be here for my daughter. You know, I wasn't going to leave her without a fight. And even though nobody was believing me, I knew that I was sick. I knew that I was sick. My family knew that I was sick. So I just fought. I just kept knocking on doors, and I refused to be quiet. I was owning my truth. And I think that's it. That was it. Just owning my truth and knowing that I gotta live. I got a family and friends that love me. And I got a life. And, you know, no matter what, I was not gonna leave my Leanne behind. Nope, not without a fight.
Yeah, so you focused on what was important to you to keep you going, basically. That's what worked for you.
Yes.
Victor, any advice for patients on how to deal with that situation from your point of view?
The situation of not being believed?
Yes.
So it's traumatic, right? So the first thing to recognize is that we do harm when we do not notice the circumstance of suffering. One of the things that Dr. Wyatt was saying is that medical education is, we need to bring a microscope to it and understand it. There is in many places, we're training medical students to think that the top performance that they can achieve is the diagnostic performance. That the main skill they have to develop is to be great diagnosticians. But being able to give a person a label can be extremely helpful and can be the initial path of healing. But obsessing in getting the right answer could also be a source of trauma, particularly if it is done at the expense of joining the person in their journey of suffering. And I find that we have many people who are very willing to pull the trigger on ordering more tests and pursuing additional exploration of things, but they're not very keen on stopping, slowing, making eye contact with the patient, maybe, you know, pre-pandemic holding of hands, and say, look, you know, I believe you, you are suffering, I'm with you. We may or may not figure out what is it that is wrong with you, but that doesn't mean that we would not care for you. The fact that patients have learned that if they have an unexplained medical syndrome, that they will then be undercared is a tragedy. The fact that we don't have a biological explanation or a psychological explanation, the fact that we cannot medicalize your suffering should not mean the stop of our ability to take care of you and potentially help you regenerate from a position of suffering to a position where you can still thrive and adapt and find the life with the disability that you have or the unexplained situation that you have. This idea that we need a label before care then displaces care, delays care, and prolongs suffering and re-traumatizes the patient. And to the extent that we continue to hold as heroes people with enormous, I mean, Dr. Wyatt had great stories, right? And I saw them too in my medical training. These people you admire because they have the eye, they can see things that you don't see. They share Holmes, model of things, just wonderful. But if you cannot get to an answer, does that mean that you do not care? And if the answer takes long, what happens in the interim? The ability to care requires opening your heart, going back to courage. The courage is not, I'm going to fight. That's not the courage. There's no real threat to the clinician except perhaps loss of reputation, if anything. The real thing is to open your heart, make yourself vulnerable so that you can connect with the patient that you're seeing who also comes in, opening their heart and saying, help me. But one of the ways of hiding that or preventing that connection to occur is to say, well, we're going to order some tests. And it's a missed opportunity to join the person suffering, say, I believe you, I know what you're going through. Well, I don't know I can't imagine what you're going through, but I can see that you're suffering. Let's work together to get through this with an answer or not, but we'll get through this and we'll make sure that you have a life at the end of this that is worth living. And I'll be with you through that process. And I'll get you all the talent that we need and all the tests that we need if we need them and when we need them, but we will take care of you. And that's simple, but it's not a celebrated skill from the time where we get trained to the time where we go into clinic, except in some very, very special situations.
Yeah, I completely understand what you're saying because I have seen it actually work in real life, and I have seen the opposite. I have seen physicians, even actually some newer physicians, who are able to be vulnerable, as you say, and say, look, I don't know what's going on here, but I can walk with you. I can be here for you, and basically offer you the gift of the healing relationship between the physician and the patient, which is very, very powerful. And then physicians who are like, well, let me throw 5,000 tests to you, and if those come up negative, there's nothing I can do. I'm sorry, you got to go somewhere else. But I think it's a tall order for anybody because it requires physicians, I think, to be very confident in themselves and okay to be wrong or okay to live in the unknown. And most people are not comfortable, no matter if they're physicians or if they're patients, they're not comfortable being in that unknown. I don't know what's your sense, but that's, I wanted to mention that.
I can, there are two things. One, I mean, in the chat, I think there's some emphasis about diagnostic accuracy. And so that, there's a sense that, to your point, that unless we're certain, we can act. And I think we have to distinguish care from treatment. We may get there, if we have the wrong diagnosis, we'll get the wrong treatment. There's no debate there. And so having good diagnostic accuracy to get the right treatment is a good thing. But that doesn't mean that care has to be suspended until we have the right diagnosis. We have to distinguish and separate treatment from care. We can always give the right treatment even if we do not know what's going on. And begin in getting comfortable with uncertainty and ambiguity is something that primary care clinicians, family docs, that's been the core, one of the core features of being and it's only in a specialty environment we have this big technology and a narrow set of diagnoses where we have become obsessed with getting it right. Staying with the uncertainty and caring while we figured it out becomes an important feature of care in patients in which the diagnosis is not forthcoming.
Yeah, thank you. Okay, let's move to another subject, which is the mistrust and distrust that Ron talked about before, and a few of the people attending actually brought up as a question. Ron, you talked about the level of mistrust in some patient communities when engaging with the healthcare system. On the other hand, the Lieutenant Governor and your life examples that you mentioned pointed out the racism, sexism, and xenophobia that sometimes exists and can affect people's lives and the medical care they receive. Desiree is another patient advocate who's here, and she posted a few minutes ago this that said, my family is from the very deep south in Louisiana. I can remember from a small child, the messaging was told to me and others in the Black community not to trust the healthcare system. I can hear my aunt saying, don't trust those city doctors. How do we change the culture and break the cycle in the community of mistrust, which has been passed down from generation to generation? The Black and brown communities need to be encouraged to change the narrative. I'm a pretty savvy patient advocate, and I still get a lot of pushback within my own family and community. So I'd like to give you the opportunity to basically expand a little bit on this. And again, from the patient point of view, what can people do when this is kind of drilled in their heads since they were little?
Yeah. So I would say, what can the healthcare profession do? This may sound radical, but I believe we're at a moment where it's worth considering. I believe we need to begin to have, as they did in South Africa with apartheid, we need to have truth and reconciliation panels. The American Colleges of Medicine, Surgery, Obstetrics, Pediatrics, Family Practice need to come to this moment and say, we need to, as organized medicine, be willing to admit that there's racism, that there's bias, that there's stereotyping, and that it has hurt people and that it has killed people. One of the things that Don Berwick said to me once is, we know that race in the US is an independent risk factor for death. And we need to address not downstream the chronic illnesses that we see, but upstream. We need to go upstream and stop those structures, those institutions that continue to throw people off a bridge. And then we say downstream, now let's see what we can do to save you. So we can save people by going upstream on this. And I fully believe, as I think the American Academy of Pediatrics has done, address this head on. And part of that has to be apologize and let's reconcile this, say that we value all people. It's not based on your skin color, your ethnicity, or any other factor that have served as barriers to receiving equitable care.
Yeah, thank you. I hope we can get there, and I think it cannot be soon enough. I'd like to bring Marjorie a little bit into our conversation now and talk about the value of support groups. Marjorie, you said in your presentation that the support groups saved your life. I know firsthand how support groups can help patients who are not heard find a way to navigate the healthcare system, ask the right questions, and become experts in their conditions by sharing symptoms. The group that you referred to has additionally done some research regarding COVID-19. And I was hoping you could tell us a little bit about your experience with this group. Like, what did it mean that it saved your life? You know, what did it do for you? And then share a little bit about the research that's being done. I know also Diana is here, and we can let her talk about that research after you're done.
Okay. Those groups are everything, because I met people like myself who were going through exactly the same things that I was going through, and there was nothing that we couldn't talk about. We could talk about our families, we could talk about the medical aspect of it, and it was just really helpful to be able to talk to people that weren't judging me, because a lot of people didn't take COVID seriously, and they still don't take it seriously. So some people were just like, you know, like I shared, they were just like, oh, you need to stop, you know, nothing's gonna make you that sick, or nothing's really, you know, it can't be all that bad, and I'm not gonna wear a mask, and I don't believe it. But within our groups, like Survivor Corps and Long Haulers, it's hundreds and thousands of people who life have been turned upside down. Some people have lost both their parents. Some people's marriages have broken up. Kids have left the fold. It's just been some really, really awful things happening behind the scenes. But when we're in our groups, nothing matters. We can talk about anything, and we can be open and honest, and we can share. And then with Survivor Corps, I mean, Diana is just, she's phenomenal, and she understands because she had COVID-19 herself. So she really, truly understands. As with Amy from Long Haulers, they both know what it's about. You know, it affects us, it affects our families, it affects our total being. So being a part of those groups and being able to participate in studies, the first study we did early on, it was about all of the different symptoms that COVID-19 was presenting. And early on, they were just saying, oh, it's 10 symptoms that COVID-19 was presenting. But when we did the study and you know, the research was conducted behind the scenes, it was like 98 different things going on with our bodies. And it was just unbelievable to see the magnitude of what was going on and all these different symptoms. And here recently, I was a part of another survey, and it pretty much was saying that, you know, people say, oh, we got to take your temperature. That's the first thing they do is take your temperature, whether you're going shopping or you're going out, and they say take your temperature. But we've been able to see that that's not something necessarily to go on, because you can have COVID-19 and not have a temperature. So just being a part of those groups, and like I said, and being around people who understand, and it just did everything for me, because it was days that I didn't have anybody to talk to, and I could go in those groups and you could just put a question out there and they start answering you, and it's just all that to me. And I know that it's hundreds of thousands of people in survival corps, and we just doing good things, and just to support the good, the bad, and the ugly side of this thing. We get to share it all, and we don't judge. Nobody is mean. You know, they have a great team behind the scenes, and you can't talk about certain things, and certain things are off limits, because with COVID-19, the load is already too heavy. It's already heavy enough. So when we go in our groups, and we don't have to worry about nobody beating us up, we don't have to worry about getting gas lit, we don't have to worry about anything. It's our own little safe haven.
Yeah. Isn't it wonderful to have these groups when you're suffering and you're trying to navigate the healthcare system? I think they are a tremendous source of support and power. I'd like to ask Diana if she can unmute herself here. Thank you, Diana. If she can share with us a little bit about the research that's being done.
Yeah, so my name is Diana Barrett. Thank you, Marjorie. Your words were, as always, just incredibly, incredibly powerful. You inspire me every day. So I started Survivor Corps back on March 24th. I got COVID on I was exposed on March 9th. I was one of the first people in the New York area to have a confirmed case and go public with it. I started the group with a mission to mobilize an army of survivors to donate their plasma and support science through participating in every trial and study for which they qualified, understanding that so many of the answers to the mysteries of this virus lie in the bodies of survivors. I thought that there would be thousands to follow me. I did not realize there would be millions at that point. And we became a patient advocacy group, I would say, as the spring progressed, when we started to see some of our members not recovering. It was in April when we, you see one thing once, you start to, and you see it 10 times, 15 times, it becomes a trend. And, I like to say that Survivor Corps has been in many ways the canary in the COVID coal mine, because we saw, we see things on the ground. We see, people like me and Marjorie, we were not hospitalized. So our experiences have not been documented by any of the medical literature. All of the studies that are coming out right now that we're reading, they're all based on hospitalized patients. And they don't reflect the experiences of people like me and Marjorie, because it's just very different. We were under no medical supervision when we had COVID. We were not given any medication. Everybody who leaves the hospital is on an anticoagulant for 90 days. That is not given to anybody who is not hospitalized. And so we started seeing, in April, a significant number of people who were not recovering. We had our first major news piece on long-term COVID on May 17th on NBC Nightly News. We've had 2,500 news pieces, both international and domestic, but 2,500 since the end of March, which is pretty extraordinary. And we realized that we were sitting on really a gold mine of data. really the greatest data set on non-hospitalized COVID patients in existence, because I had started it so early. And so we had people's real-time accounts of their experiences in real time, that they were recording in real time. And so we teamed up with Indiana University School of Medicine and with a professor there whose specialty is using natural language and turning it into real medical data, and using social media in particular, because that's where people go now to talk about their symptoms. And as you were saying earlier, Marjorie and I probably know much more about non-hospitalized COVID than most general practitioners in the country, if not the world. You become an expert in whatever you need to. And so there's a tremendous amount of wisdom in this group, an amazing amount of information, and a wealth of stories and experiences that needed to be turned into actual data. So we put out our first survey in July. So as what Marjorie referred to, when the CDC increased their number of symptoms from 4 to 12, we announced a survey. We put out a survey of 98 symptoms. So the 1,000 articles that you saw on hair loss, that was all because of that paper that we did. We just put out another one last week showing that temperature checks are nothing more than medical theater. 4.6% of adults, while contagious, have a fever. 4.6 of adults. You have to assume a far fewer number of children. And there was no symptom that was far and above, a great indicator of being contagious. The most frequently reported one was 15%, which was simply fatigue. Fatigue, headache, and shortness of breath ended up being the top three, using, what's it called? What do they call it? I can never remember how to pronounce it. The oxygen meter. You know what I'm talking about.
Yes.
Using one of those would be probably a much better way of screening at a front door to see if you have a lowered oxygen rate than taking somebody's temperature. And so we are working on multiple levels. So we have our community in the Facebook group, which I like to refer to as the epicenter of hope, because it really is a remarkable virtual place where we are living in the most fractured political and social times of our collective lives, and we have managed to carve out a corner of the internet for over 110,000 people having the most civil, supportive conversation anywhere in America, let alone on the internet, which is not exactly known for being a kind, supportive place all the time. So we have that. We have a website, survivorcorp.com. You can go there and you can look at any of our studies are listed there. We do a series of webinars. So I just did one with Dr. Will Lee, who's a vascular specialist. I did one last week with the head of cardiology and a top pulmonologist from Mount Sinai. Done one with a psychiatrist on mental health issues in the time of COVID. Done one on T cells, one on plasma at the Mayo Clinic with Mike Joyner from Mayo. We have one with Dr. Fauci coming up on the 30th, which will be very exciting. It was originally supposed to be on the 4th, but that was the day the president got diagnosed with COVID, so we were switched to the 30th.
That's amazing. That's amazing work, actually. That's so much produced for such a young.
And that's really that's just scratching the surface. There's so much more. So we are really trying to move the conversation. We are trying to work on the policy level as well. So I'm sitting on a general accounting office panel on disabilities next week. Because we are looking at the largest group of young disabled Americans in our history already, and that's including wartime. Right. That is sobering to say the least, right? And
I agree. And actually, we want to talk about long COVID, and if you don't mind, I want to move into that section because it's very important, and we have a lot of questions about it, and we only have 10 more minutes. And
I'll just squeeze in two quick things, and then I'll let you. Then
Yeah.
I'll be quiet. So just a couple of other things we're doing. We set up a longitudinal study with Columbia University, which will study. It's called Recovery Corps, spin off on Survivor Corps, and it's a longitudinal study tracking people over the course of years, both serologically and symptomatically, run by the famous geneticist Wendy Chung, which is super exciting. We are putting together a medical advisory board trying to identify therapeutics that will keep the disease from progressing for patients recovering at home, and also how to treat people who are suffering the damage of long-term COVID and its vascular effects.
Yeah. Well, again, this is so much work. It's unbelievable. I think congratulations, huge congratulations is in order, because organizing a community is one thing, but organizing and then making it productive is another. And this is a huge community. So really congratulations for all you're doing. And I'm personally looking forward to all of the research that's going to come our way.
I'll be on Brian Williams tonight at 11:40 if anyone wants to tune in.
There you go. Okay. Thank you. All right. So I'm going to move into a very close subject, which is the long COVID, actually. And we have started reading reports, and of course, Marjorie's story is on this subject about people having COVID for a very long time, or having symptoms that maybe they didn't get diagnosed, but it looks like COVID, and it looks like a long-term disease. And some providers have already expressed concerns that long COVID may turn to be a baffling illness like chronic fatigue syndrome or other post-viral infections, and that they will not know how to diagnose or how to treat it. There was a Medscape article recently that suggested there might be 4 different syndromes making up long COVID. I know Diana is shaking her head, but I'm just reporting what it said. So I'd like to ask basically Ron and Victor from their experience as medical professionals, what similarities do they see in long COVID today, at least with the initial presentations, with the medically unexplained chronic illness that David Myers pointed to before, and of course the chronic disease community knows for a very long time. Chronic fatigue, ME, it looks the same to a lot of patients. So we want to hear from physicians. Do you see any similarities here?
Yeah, I'll just be brief and hand off to Victor, but I think it's important to, as I started out, to understand history, and I'll go back to Joseph Power, who taught me. Joe would say, if you know syphilis, you know medicine. If you know lupus, you know medicine. If you know lymphoma, you know medicine. And then it was, if you know HIV/AIDS, you know medicine. So I have every faith that as research and as all the people like Diana is making these contributions, we will know COVID better, and we will figure out ways to help people in all of its manifestations over time, and see this as the next phase of a disease process where we'll understand the natural history. We'll begin to understand the nuances of it. And even the diseases I just mentioned, we are still challenged diagnostically with every one of them. So we continue to learn from these diseases. We learn from the people who have been impacted by these diseases in every possible way. So the research is important, the education is important, the sharing the knowledge is important, believing people is extremely important as we learn about these diseases. So for that, I'm optimistic and hopeful that we will learn much more about this disease over time. We just don't know at this point what we don't know. I'll hand over to Victor.
No, I'm not an expert on long COVID. Diana is an expert on long COVID, and her team is an expert on long COVID, so I would not mansplain long COVID to Diana.
Okay, thank you for that. I would actually like to point out that there's hope, I think, here from Ron's point of view, that maybe with all the folks on long COVID, all the ME and chronic fatigue syndrome people will see some light at the end of this tunnel, and they have fought for a very long time to be taken seriously. And I know that Diana wants to talk.
Oh, I said we've been working with them. The chronic fatigue, they've reached out to work with us because I mean, what we're doing will hopefully have a trickle-down effect and help loads of people, you know, suffering from various ailments. But the one thing that I just want to point out with long-term COVID is that because it's a vascular disease and it's impacting every single organ after the fact. So it's beyond, you know, fatigue issues and the neurological issue. That's part of it. But we're seeing heart attacks and strokes and, you know, really profound issues.
And I'll just add that here, right away, we have a known agent. We know that it's a virus. We know a lot about the biochemical makeup of this agent. We know a lot about how it performs, how it acts. And what we also know about viruses, and I don't think this was any different, maybe way more aggressive, is that viruses shift and drift. So the virus is learning also. The virus is learning how to survive. So as we research this and begin to understand how to get rid of this virus before it can do the kind of damage that we're talking about here, is to understand that we have the agent. And so that again gives me reason to be optimistic about what we will learn and how we will begin to better manage this illness, which a big part of that, I believe, back to Marjorie's point, really is early detection.
Yeah, I do have a question that perhaps might be you know, in I find it challenging, and I'm not sure that's the right word, to see the community with the chronic fatigue syndrome and these other unexplained medical syndromes come on board and get on board with the long-term COVID sequelae of this infection. They do seem like very different conditions to me as well. And I am concerned that the challenges of that community may actually limit the success or impair the success that might follow from a deeper understanding of what long-term COVID and the COVID sequelae represent. What do I mean by this? The community of patients with chronic fatigue syndrome is a suffering community, but it's a suffering community that holds a duality. On the one hand, they would like to be believed in their suffering experience by virtue of the experience they have. On the other hand, they condition their response to treatment to understanding the biology of that experience. And so in the absence of the biology, they don't feel that their condition is truly believed, and their experience is not enough to claim a response for suffering. I might be making a cartoon of their position, but that's a challenge that I perceive. I don't think that's the problem of long-term COVID. Long-term COVID is evolving. It's a condition that we are beginning to understand, that the understanding is evolving. There are multiple hypotheses. There are studies that might be going on to try to understand what is what. Is there a heterogeneity of responses? What are the susceptibilities to one manifestation versus others? The kinds of things that we see with other conditions triggered by infections. But I struggle when my patients have those diagnoses. I take care of people with diabetes, and so people with diabetes don't usually have diabetes. They have diabetes and everything else. And I struggle because it is hard to respond to the suffering and then feel that there's a demand for testing and evaluation, which for the last at least couple of decades has not been successful at moving people from I have chronic fatigue syndrome to I now am a thriving person. There's a group in Norway that collects information about people who have, been able to get out of that box of having that diagnosis. And it's interesting because there's no single strategy that they follow, but they've been able to overcome it. And I find that a much more hopeful strategy. Who has been able to overcome it? What makes them different than everyone else? What did they do? And try to figure out strategies forward. But I'm a little perplexed and challenged by this sort of mimetization of chronic COVID being similar to chronic fatigue. I'm not sure that's the right approach. And it may actually be a disservice to people like Dr. Marjorie Robertson, who actually have a clinical condition that might deserve a different kind of response.
Right. Thank you very much for that. I wish we had more time to discuss all of this. but we have now less than a minute to wrap up. I want to thank you all very, very much for being such a wonderful participants in the Q&A. I want to thank also the audience for posting such wonderful questions. We didn't get to all of them, but at least I think that the most important ones were answered. And I would like to hand it back to Helen, who will kind of conclude the entire section for us.
Thank
Well,
you.
yes, thank you all for a really vibrant discussion. And thank you so much for joining our panel at the last minute, Diana. That was terrific. So the pleasure of doing these summits is that I get to invite my favorite people to come speak. And this has been really, really nice. So I hope that we can sort of continue this discussion in another forum. There is a message board in the Pathable program. So if you all want to stay in touch, you can send messages there, and we can try to sort of get something together. We also have a little LinkedIn group, right, Io?
We do indeed.
What is it called?
We have to find it and send it out maybe via email.
Anyway, yes, thank you for everything. And we will be in touch. And I hope that this will sort of become part of our diagnostic community, the long COVID issue and the long COVID community. Thanks, everybody. And enjoy the rest of the conference if you are registered. Bye-bye.